So, Bruce Thompson, as Head of Health Sciences at the University of Melbourne, what do you feel are the important risks of using artificial intelligence to engage users about healthcare?
So this is kind of an interesting question because we're starting to bandy words around like artificial intelligence as this brand new thing that's floating around that is going to be the saviour of the whole world. And I did university a little while ago now, like a long time away, and we were doing it then. So machine learning, artificial intelligence, neural networks, the whole bit was all been around for many, many years. And ultimately it's really a bunch of regression equations to actually simplify complex information. So it's just a method to get a whole lot of information and try and distill it, find the needle in the haystack. So therefore, but the good thing about that is that we can actually do that. But now we're wanting to use it and apply it in a way where we're going to be trying to tease out information and have a two-way conversation with something that's actually really has a mathematical basis behind it. So where the whole thing can go wrong is it potentially goes down a pathway and then potentially can't bail and bring it back onto the actual rails again. So that's where sometimes the issue can actually happen, is the exit strategy. And it's the same for any type of technology that's around that has some form of control, is what do you do when it starts to go wrong? So when you're trying to implement something like this, what we need to do is treat it no differently to a drug. When we use a drug, we have a randomised controlled trial. We use standard methodologies to try and work out whether it's efficacious, whether it's better than the standard treatments, and actually has some form of clinical benefit. In this particular case, it'll have a very similar process, where we actually try and understand how efficacious, how actually beneficial it is to an outcome that we want to try and achieve clinically.
When you say it goes wrong, what do you mean by going wrong?
So, say if we're actually using this particular process and someone who has significant signs of doing self-harm, and it just misses it. Now, humans miss it. I think everyone who's a psychologist has got war stories to tell where I missed it. But what we're dealing with here is we don't actually have that control. Mind you, it may pick things up that others mightn't as well. So that's the good side of it.
How could it do that?
So basically, as I said, it's looking for the needle in the haystack. We are talking about people, especially when we're talking about, two-way conversation with anybody. And even though all best intentions, you may be thinking about the person in front of you, however, things may be distracting you just may miss something. And that happens because we are talking about people.
But you think it could pick up things that a person might miss? Did you just say?
So absolutely. So, and that definitely happens with lots of other forms of technology that ultimately you, especially in, say, using AI and imaging, for example, for X-rays and what have you, the good thing about it is they potentially be able to find the same things over and over again. There's not as much variability. So, and it potentially can actually find things that are not everyone can find. So therefore, you potentially can pick up some things. But then there's always the trade-off between what it might miss. And so that's what we need to start reconciling, because if you say you missed a catastrophic event, who's responsible for that?
Has anyone got anything else to say on that?
I'd just add, I think there's three things. I think there's technology to reduce admin burden, which the technology is much better than the human at doing. So, practical example, Sal Bradford did her PhD looking at the HEADS assessment. It's an assessment tool. Basically found the technology was 9 to 10 times more accurate than the actual human in doing a pencil and paper survey. Took less time. When you think about that, reducing admin burden takes the time from 2 hours down to a 15-minute consult. And then in real time in front of you, you've got the data in front of you. That's a really classic example where there is an error. It just is self-report, but using the technology as an administrative tool to reduce administrative burden. When you think about burnout for psychologists, burnout for professionals, an amazing way in which you can think about actually using a tech for good to cut down on all of those issues. When you think about it as an intervention tool, so how do we use it to actually improve or enhance those communication strategies, whether that's between human and machine, or machine and machine, or human, machine, human, that becomes more complicated. But again, if we look at it from a human perspective, humans make mistakes, machines make mistakes, machines are better able to pick up those mistakes earlier. And then I think the final piece is from a measurement perspective, we've been relying on subjective measures forever. People make mistakes. So we either underreport, overreport. As a clinician, you either miss cues, you don't miss cues. The machines, what we're hoping to do is anticipate that they'll be better able to be less subjective, be more objective. So I think there's the three buckets, and they're all different in terms of the ethics around the use of those tech.
Could that be, when you're comparing a machine to a human, is it human gets tired or has some sort of frailties that sometimes the machine doesn't have? Is that what you're alluding to?
Well, I think humans are humans. They're empathic. They bring a whole host of subjectivity to it. Machines, at the end of the day, are being trained by humans. So it's a chicken and an egg. But yes, we get tired, we get burnt out, we become subjective, we bring in our own biases.
Can I add to that?
Yes, please.
My actual field, my discipline is information systems, so this is something that's of great interest to me as well. The advantage of using a computer is that they don't get bored, and they can do the same thing over and over and over, and they'll be just as good every time as they were the time before, which is terrific because humans get bored and they get tired, and they've had a fight with their partner last night, and they've got a sick cat, or whatever it happens to be. There are things that affect their ability to make rational decisions. But on the other hand, if you're using a computer, say, for diagnosis, a human might look at a patient, a human doctor might look at a patient who comes in and say, you know, I know all the symptoms are trending in that direction, but I just have this feeling that this person is one of those rare cases where they haven't actually got what they appear to have. They've actually got that. And a computer would never in a million years do that. So they're great for diagnosing, particularly things like expert systems. They're great for diagnosing standard stuff. And they'll take a lot of effort away from humans so that they can concentrate on the really tricky stuff. And this applies to scans as well, that if you're looking to find out if there is you're doing brain scans and you're looking for a tiny, tiny brain tumor, a computer will be great for that because they can do all that kind of pattern matching. But they won't necessarily think, there's something odd about that scan. What is it? I know it's a such and such, and they just don't do that sort of thing. I guess it comes back to the fact that computers are logical, but they're not reasonable.
Thanks, Paul. Thanks for that. Peter, were you going to say something?
I was, and I agree very much with what was just said. Much of my career I've been focusing on diagnostic systems and understanding of the structure of mental illness. And one of the difficulties I think the AI will run into is our diagnostic system is terrible. It's not nearly as refined as what you see in other areas of medicine. NHMRC and NIMH and all these other agencies have poured millions, if not billions of dollars into trying to find biomarkers or certain things that can say, yes, you've got this, you don't have that. We've got a system with DSM that has not better accounted for and must cause clinically significant this. Issues of rampant comorbidity. When the person doesn't have 4 or 5 things wrong with them, they've got one thing wrong with them that needs 4 or 5 labels. So one of the concerns I have, and I don't know much about machine learning and AI, but a system where if I'm sitting down one-on-one with a client, I can see that, okay, they may have, technically meet criteria for this and that, but it's all better subsumed by their generalized anxiety disorder. And I run into that a lot with my trainees when I'm working on, doing diagnostic assessments, is they're slapping a label onto everything that they technically meet criteria for. And we see that in the national comorbidity surveys and all these telephone surveys where you have untrained people who are just going through a simple checklist. Wherein, I've yet to see a person where I think they've got 2 or 3 distinct things wrong with them, or 2 or 3 diagnoses. They're one person who's experiencing difficulties that we may sometimes need labels for. And I think the nuance in being able to distill it down into conceptualize it as, okay, so it's really just an unusual case of, say, a specific phobia of vomiting, but it's got some characteristics of obsessive compulsive disorder because they're trying to get the germs off their hands so they don't get a stomach flu. And they've got some examples of perhaps some symptoms of an eating disorder when it's simply they're just trying not to put food into their system because they don't want to feel like they might vomit. So I don't know enough about AI to know whether or not that nuance could be built into the system, but I know at least even for therapists, it can be very difficult to distill down to what's really going on, as opposed to just using a DSM checklist.
Robin, did you have something?
Well, so first of all, my notion of a consumer representative is a person, an intelligent person asking dumb questions. So this might well be a dumb question, but so what I've heard is that this system could go wrong. It could misdiagnose. It could there could be false positives, false negatives. But the broad issue for me is, well, does this have the potential for the population at large, produce a better result? So am I thinking right if I use the analogy of the issue of self-drive motor cars? $35 billion is what road accidents costs us in Australia every year. And I don't know how many lives and how many injuries. But theoretically, self-drive motor cars will reduce that to some small percentage. But they will cause accidents and they will cause injuries and some deaths. So what the community will have to come to grips with is whether we're prepared for machines to do bad things occasionally if they do good things more broadly. And
that's right.
That's what that seems to be the big question with the technology we're talking about here.
So that's what I was saying about that's why we need to do the studies.
Yeah.
So it's no different to do a randomised controlled trial where you find out there's a certain mortality associated with it. That could be fine, 100% fine. But we need to work out, this is not, I think, a straightforward study to do. So you need to work out how do we demonstrate that? That's in a robust way. A couple of things that Jane mentioned before as well. Sometimes if it's just to save time, then that's a lot easier. And that's a great thing. So all we want to do is just ram these things through, 2 hours down to 10 minutes, perfect, no problem, no harm done. But when we're starting to get into the grey area of all this, that's where we need to start looking at the population level on whether we're doing more harm or less. Vaccines is a very good example that we've just been through, where ultimately they have side effects that potentially actually can kill you, but the chances of that happening relative to contracting COVID is minuscule, and it completely changes the nature of the...
I just feel we're jumping the shark, like really we've into the heart of a clinical discussion already, so if we're going to collect data, it seems to me it has to be purposive. Okay, there has to be a reason for that. We're next door to the Optus building and we know what happens if you collect data for data's sake. So I don't think we've said, given an answer or started to grapple with the problem Robin identified, and that is, what would be a better result?
Yes.
Okay, and it seems to me when you talk about that broad spectrum that's mental well-being and health, we're going to have to differentiate certain things. I don't see this approach as essentially about diagnosis.
Right.
Okay, I use artificial intelligence in diagnosis. I'm one of the few psychologists who still tests, and I use an automated version of the personality assessment inventory, which people self-report on, and then it prints out a little report for me that says, consider these things in formulating your approach to this. I must say I do that. But a lot of the information that I take into account is not what's generated in the self-report anyhow. It's background information, it's the dissonances between observed behaviour and reports, so there's a whole lot of information in there. I just think if we took 2 steps back from this sort of, could this possibly misdiagnose, and, are we talking about generalised anxiety disorder, and said what would be good results in terms of better care, support, and perhaps treatment too, for people who are experiencing psychological distress up the top end, right through to genuine mental illness. And I think there's going to be different answers at different stages of that continuum. I would say this type of approach is likely to be very helpful up that support and care end. I think where we'll run into difficulties is when we start taking a limited set of information, and that's what we'll have in the end, and trying to take that through to the what you might call treatment end of the spectrum. So it wasn't meant rudely when I said I think we've jumped the shark. We've sort of gone to the pointy end of mental ill health too quickly. What's last point? I've got 2 minutes.
No, that's fine.
I mean, the good thing that's happened in our community over the last few years is, especially with regard to anxiety and depression, we've destigmatised the reporting of psychological distress. Okay, when you look at what we've done down the pointy end of treatment and acute care and stuff, that there's a whole lot of other things. But so you will get people self-reporting up that front end. We know that sort of distress can lead on to much greater dysfunction and ill health. So I'd like to see some differentiation in our discussion where we could talk about the value of these things at different stages of the process, and then the safeguards we'd have to put in place to make sure that it did its job well. That's it.
I might build on that, Terry. I think we've been providing mental health awareness training to several government agencies and certainly many private agencies and organisations. And pre-COVID, face-to-face was standard training. And one learning was during COVID, we all went online and everyone had to pivot, and we provided training via Zoom. And initially, people were very intolerant of Zoom, and certainly there was changes over time. And during the training, people were very tolerant of children interrupting sessions, they were tolerant of animals interrupting sessions, they became tolerant of technology. So as a community, I guess that we can change. What we found, and in the evaluations we did of this training, and this is only very simple mental health awareness training, we're not talking about diagnosis or anything there, is that I think there is a tipping point where it was becoming a little bit too much technology and too much of the Zoom and the e-learns and things. And that's just kind of a sample how, people are starting to embrace technology, I think, a little bit more. But there is a tipping point, coming back to your point, Terry, that I think stages is really important, which actually also, Bruce, speaks to your point about NARCT, also unpacking, and identifying where those stages of helpfulness.
Is that tipping point from the point of view of you educating, or from the people receiving the education?
It's the people receiving it's the technology.
The user or the patient or whatever, there's a tipping point where they can only take so much technology. Is that what you're saying?
Absolutely, yep.
Chris, can I make 2 points? And I think it picks up on Robin's and also Terry's. The public health intervention model is well known. It's been well known in cardiovascular disease, every other chronic illness. 1994-96, they introduced the Institute of Medicine framework, which looked at preventative interventions for mental illness, wellness, early intervention, clinical care, relapse, and then mental health promotion along the bottom. That's a well-known model. It's not new. It's been around for 30 plus years. It's a public health model. It looks to reduce risk, enhance protective factors. I also think we need to look at technology and start to talk about actually what technology is. It's not Skype. Technology has been around. You know, Reach Out was introduced back in 1996, 97, the world's first online mental health support for young people. It was peer-to-peer online support, evidence-based provision of information. And fast forward to now, it took a pandemic for us to actually think technology was some amazing, new, wonderful thing. But we really need to, I think, dispel the myths of what are we talking about when we talk about mental health? Are we talking about mental illness? Are we talking about mental health promotion and wellbeing right through to clinical care? And what do we actually mean when we talk about tech? Are we actually talking about delivery of services through Skype or online awareness programs? Or actually, are we talking about smart data, artificial intelligence? If we move into augmented reality, virtual reality, it's a whole new world of technologies that there are lots of clinical trials. The challenge is in implementation across into practical application, and that's what we're really poor at. And I think the final piece of the puzzle, all of our investment goes into treatment. It's low quality. Anyone who's been through the system knows that it's a challenge to get high quality care unless you're actually lucky enough to find yourself with a good clinician, people who actually measure outcomes. And our big challenge is how do we start to think about shifting the dial from poor quality treatment to high quality treatment, preventive interventions, and the use of technology to augment promotion, prevention, early intervention, treatment and relapse. And they're the parameters I think we should be thinking about in terms of where to from here. Lots of evidence, not much in implementation science.
I've actually got a note here on clinical governance because I think that that's key to something like this working.
Have you got anything to say, Jeannie, just at this point?
Well, I think the point that we need to think about what kind of technology we're using is key, because there's actually, there is a world of difference between using an automated but pre-existing diagnostic tool and speeding up the answers, popping them in and basically producing the outcome you would get by paper. And I think what we're talking about when we talk about AI, which is using large amounts of data, and I'm assuming a machine learning model to find different types of correlations to identify the precursors of not mental well-being, if not mental ill health. And one of the points I think here is to be really clear about the type of technology that's being used, because the risks are quite different. Because we understand how those expert systems work, we write them down and then just automate them. When we're talking about artificial intelligence, we actually don't understand. We understand the data that we're asking for, we can measure the outcomes, but we're not necessarily sure about how the correlations in the training model are reached. Now that might give new insights, but it probably also requires expert oversight to make sure that those correlations are valid and not harmful. And for me as a lawyer, the important thing is if you're not diagnosing, that's that bit, there's no therapeutic requirement for testing and trials and the like or approval. This is unregulated except for general consumer protection law. So that precision about the technology being used and how it's being used, I think, is crucial to the conversation. And, you know, come on.
Can I ask Robin a question? That was just my first question, by the way. So. But that's great. Thank you very much for all your help. What I had a question here was, let's start breaking it down, which was, and Terry sort of got us back to that area. Let's break it down into just where the bot is asking people questions, okay? So, in your opinion, from a consumer point of view, or from your experience, how far should that go in terms of, because you take a clinician sits down there and asks questions, right? You can say, oh, well, it's just about asking questions. That's for someone who doesn't really understand the complexities of the whole thing. And bots ask questions, so yeah, okay. So how far does AI should go asking questions before it stops and hands it over?
Well, one answer I had to that was, well, as far as the person concerned wants it to go. But I guess the problem I got with that is the initial issue of informed consent. So to the extent that this is a therapeutic intervention if that's the right sort of label, then I would be thinking that there ought to be informed consent on the part of the consumer, client, whatever, to participate in this procedure. And if a human being is seeking the informed consent of another human being, that's kind of one thing to me. The human being can make a judgment as to whether the other person is understanding what they're being offered. So I am wondering to what extent this artificial human being can make that judgment. I occasionally have to bear witness for powers of attorney, and I've got to decide whether the person signing their powers of attorney has their arm twisted behind their back and whether they've understood what they're doing. So, and I just wonder to what extent a machine will be able to do that. And of course, there are additional issues with that if we're talking about children using this system unsupervised. I don't know whether that's actually contemplated. Getting across all the information that you, I think, do need to get across about what is going to happen to the data that the person's providing, who's going to have access, as we talked about earlier. So there are some questions I've got at the outset.
You know, we usually have people have to sign a thing at the beginning, but what you're saying is someone can get into it and say, hang on, this isn't what I signed up for. This is. Did I really know it was going to go here?
Yeah.
Or was I going to end up feeling like this in this interaction? Those sort of things. That's what you're talking about to some degree.
So, but then pursuing the question of how far should it go, my simple answer was, as far as the person wanted to go,
Yes.
as long as they've understood what's going on. As long as we're sure that they've understood what's going on. It seems to me there ought to be a very, very ready way for the person to opt out at any point, as soon as it's becoming not comfortable for them.
Push this button and exit.
And again, I just have, I guess, a bit of a worry that there might be some people in this situation that feel, I really ought to go with this, keep going with this, I ought to keep going with this, and maybe they shouldn't. I don't know. So it's just, I'm asking that question.
You had something to say on this, Peter?
Yeah, well, just following on to that, and I'm sure our HREC chair sees this all the time, but a lot of times we know simply asking about things can actually increase the level of distress that a person's experiencing. So if I turn to you and say, tell me about that sexual assault, we're going to be putting them in a very emotional state. And if they hit the, cancel this session button, are we now leaving them in a worse state than when they came into the game?
Yes. Paula, did you have something to add?
Yes, but not at all on that line. My line is concerned with data and where it goes to, bearing in mind that I'm wearing two hats at the moment. Let me take the example of Fitbit, for example. It used to belong to a company. It was invented by a company called Fitbit. And people bought them and they attached them to their bodies, and it collected all sorts of sensitive personal data. And then Fitbit was bought by Google. And all of a sudden, the data that people thought was going to one company is going to all of Google's many, many, many connections. And we know they sell their data to anybody who'll pay them the right amount of money, and they mix it up with other data and they do all sorts of highly improper things with it. And they get away with it because they're so big, they're too big to do anything about. So that one of the concerns I have with this whole concept is at the time that you set up the software, you may well have a cast iron contract that says, and I'm sure the lawyers are going to get involved in this in a minute, that says the data will only be seen by so and so and so and so by such and such a group. It will never go any further. And then suddenly the company gets bought out by somebody bigger, or somebody bigger than them, or somebody bigger again. And all those contracts are completely meaningless because the data will go where the data will go. And somebody earlier mentioned Optus, and I'm one of the lucky people who's an Optus customer, and I can't tell you how happy I am. And I agree, why were they connecting people's Medicare numbers? Fascinating. Anyway, passing lightly over that, I think there is a real issue that once you put your data into an automated system, the agreement that you have at the time you sign may not be where your data ends up ultimately.
Judy, can you give us a bit of a legal...
Well, I am the lawyer here, I think.
I know.
Okay, so first of all, the Optus breach, actually there's been a bit of a double game that's being played by the government. A lot of the data that Optus collects is required to collect by law. So it collects a certain number of data points, passports, a driver's licence, Medicare cards, because it's required to do so in certain circumstances by the federal government to prevent fraud. And in fact, the federal government also says yes, I know. So the government's playing a double game. The government also says that Optus needs to keep that data for a certain amount of time. So the Optus breach is distressing, but I'd have to say it's not just... It's a more complicated story that's being portrayed. On the point about whether data that's collected by contract can then have other things done with it, actually under our privacy law, with sensitive personal data, consumers have to give consent to what's done with that data, and the data can't be used for secondary purposes. So it can only be used for the purpose for which it's collected. Now, we can be cynical or not cynical about that, but the point is the law actually does say that data that's collected for one purpose can't then be repurposed unless consent has been sought for that. Australia at the moment is about to have stronger privacy laws being brought in. I believe, and I've just heard today, they are sitting on the minister's desk. He's just making them stronger, which will take us to a position that's closer to the GDPR, which, as you will know, sitting on an ethics committee, has quite robust protections about data. Yes. Now, I'm not saying it's perfect, but there's protections are there. If we think about chatbots, actually many of us are dealing with chatbots all the time because most telcos also use chatbots to collect information and solve problems with them. We recently did a survey of people who use telco chatbots to see if they understood how they work. We were surprised because we thought it would be like Eliza, that people would think it's a person. In fact, consumers had a quite sophisticated understanding that it was an artificial person. So the data collection and the confusion points are really valid. I think they can be met. I think that where we run into problems perhaps is when we start talking about children, because children are in a quite different category. We generally think that their privacy should be preserved to higher standards, and you will all know that asking children to consent to actions that will affect them in the future is quite difficult. That's the case here too with data and privacy.
So can I ask a question on the privacy? When does this data become a medical record? And is it actually, is that different under law than a standard private document?
Well, it's not if you're talking to a chatbot and you're not in a medical context, it's not a medical record.
But in this particular case, we might be asking sensitive,
yes,
confidential information about their mental health.
Pre-chatbot, and this was my concern with the online services which are anonymised, and so there was Reach Out, Lifeline, Kids Helpline, Headspace. Kids could jump from one to the next, to the next, to the next, to the next. You didn't know how well they were, how unwell they were, what services they needed, whether they should be speaking to someone face-to-face. You had absolutely no measure of that because they were anonymous. And so I look at it and I think there must be a better way of supporting our children and young people through better conversations, better ways of working, better ways of using the technology, because that model is broken. And I think, again, Robin, to your point, we can make sensible decisions about opting out of particular engagements online. But as you become unwell, you're less likely to be able to make those sensible decisions. In fact, you're more likely to be more engaged. And in fact, as you become more unwell, and particularly in the veteran space where I work, you're more likely to engage and engage and engage and engage. And it actually does create that negative impact until you are almost in a cycle of despair, which creates that cycle of unwellness. Yes. And so they're the concerns that I have, not about the technology per se, but about how we as humans interact with the technology and how we haven't thought through the safeguards that we should be putting in place, because we come up with these great ideas of anonymised or online because you don't want to be judged, and yet we don't think through the consequences of what is actually happening in those spaces.
And actually, that idea of anonymised is changing, because most interactions that we think of now online as anonymised, I don't give my name. Young people commonly say, "Oh, I didn't use my real name because I didn't want to be identified." The law, our understanding of that is changing now, as Joan, I know you're very well aware, where identifying personal identifiers online are not as important as the browser you're using, the device you're accessing it through, your typing fingerprint. There's a whole lot of other identifiers. So they're probably those interactions that are increasingly not anonymous anyway, and we shouldn't pretend that they are, because they're not.
I just had one more point about the question of how far things should go. I can imagine a person using this technology at some point saying, "Oh, I've had enough of talking to this machine. I want to speak to a person." And then if it's not readily feasible to put them in touch with a human, what might be the consequence of that? So, just a question.
Yeah. Well, we tend to direct them to Lifeline or something like that where we know they can reach a human. But again, it depends how far down the line that Terry was talking about, where you are in terms of your mental health.
And that's really
whether
hard
someone
for
should be sent to Lifeline at that stage when it would be an overt reaction.
And that's really hard for the clinician who's going to land that particular client. And they've said, so where you've been up to? Oh, look, I've been using this little baby for a while, and it says I've got this, and this, and this, and this, and they're going to be going, oh, great. So how do we unbundle that? And it could be right. It could be 100% on the money, but it's within how do you actually do that crossover from...
Yeah, so can I ask you the question? The question we have here, I'm just twisting it a little bit, the relationship between the psychologist community and the little baby here, how much support should it get? Should the psychologists poo-hoo it and say stay away from it, or should they support it, or is it qualified support, or what should be the you representative of the whole community, what should the relationship be with?
So in a medical model of healthcare, that's where guidelines come into play, and so this is well documented. There's a whole swag of publications demonstrating that it's efficacious, it does what it says it's going to do, and it has a benefit. So and it's known. Potentially in international guidelines, could be in the DSM, it could be whatever it is. So when the clinician actually goes, yep, I got it, I'm all over it like a rash, no worries, I can take over at this point. If you can achieve that, that's what you want to do. So, but there's a fair way to go.
No, sorry, if you want to go somewhere else. I just want to revisit what I said before. To give consent, you have to know what you're consenting to. I say that to collect data, the other side of the equation, there has to be a purpose to it, a beneficial purpose, I would argue, too. And I don't think... I think we can again disaggregate a bit by talking about different purposes for which we might collect data. I don't think, long run, there's going to be much problem with collecting data to give feedback to users about their current situation, broad as I can, and what would be a recommended course of action for them at that stage. Okay, so I think that's only a step further, Jane, I'd say, than the things that have been around for 30 years, if you give easy access at the end of the process to those recommendations. So I think once you move to collecting data that you might report to employers about or health professionals about, you're into some of the thorny questions here that people have started to discuss. And so it's a question of what you mean by artificial intelligence. There would be good enough ways to collect good enough data to give people relatively good self-reports, I would say. I don't think that's going to be a problem. And it would be useful to some of those people if that report then enabled them very easily to move to the level of care, treatment and support that they need. So none of that, but they get a choice again at that stage about whether they want to do that. But the other two, once you're going to report to employers or to health professionals, I'm starting to get a little bit uneasy about.
Well, can I ask the question, who owns the data?
Well, can I ask a related question?
Yes, please do.
What's occurred to me is who is responsible for what's going on here? Who owns the data? If the responsibility is going to be taken by a registered psychologist, then all the laws and what have you that relate to that come into play, I assume. And the arrangements for notifications of things not being satisfactory come into play. So are we actually talking about the responsibility for this system being held by a registered psychologist?
It depends on what you're using it for. If it's a medical record, I own it. That's my understanding. I own my medical record. No one can legally hand it over to others.
Not in Australia. Not in Australia. Your doctors own the medical records related to that consultation. So if you have, for example, seen a GP and then, I don't know, an orthopaedic surgeon about a problem with your hip, the GP owns the records that relate to their visit and the orthopaedic surgeon owns the records that relate to that. And they can choose to share them with you or with each other. But you do not. Australia is a little unusual that we do not own our medical records.
I think that's what Bruce was saying.
That's what I was saying, but they're the custodian of it. I can ask them,
Sorry?
they're the custodian of it. I can request that data and ask them to delete it. So ultimately, it's
And they can charge you for that.
You can use a tech platform to integrate your data. So PsychWire, as an example, psychologist-led, psychology-driven tech, artificial intelligence that connects psychologists to patients. They use a smart algorithm to match the needs of the client to the needs to the quality of the clinician. The person is positioned as the owner of their data.
The consumer, they don't own their data. Consumers don't own their data.
They share. They make a decision about sharing their data, which is very different to ownership. But that's where it becomes the consumer-led as opposed to a medical-driven decision-making about how to utilise that information. Not data, that information. On the workplace wellbeing one, Spring Day, for example, has been around since 2009. Workplace wellbeing program delivered across major industries. Decision was, and the information was provided that the data would be de-identified, but based on different divisions, so that you could see where there were weaknesses or strengths in the ways in which wellbeing was approached.
I guess what we could do with data, what we did 20 years ago with information collected, we view that through a different lens now because we're much better at processing data. And I think if we talk about the sharing, just to pick up on Robin's point, if we talk about the sharing of data with employers or even parents actually, once upon a time we'd go, well, we're just sharing some anonymous statistics, but we now have the capacity to do much more with that data. And there is the real concern of consumers or employees that data can be re-identified. We know you only need 3 data points to re-identify supposedly anonymised data, right? So you can re-identify it, that's one thing. The other thing is that if you happen to be the outlier in the data set, we're going to know, your employer will know who you are anyway. So data privacy has changed with technology advancing. And that doesn't mean we shouldn't share or use data, but it does mean, I think, that the considerations now about data collected through digital devices are different from concerns 10, 20 years ago about data collected through interpersonal interactions or even telephone interactions, because we just didn't have the capacity to process the data we do now. And part of the problem with the consent processes is not that we don't ask them or that they're binding, but people don't understand them. So we're giving away too much because we don't know what we're giving away. And that was the problem with Fitbit. If Fitbit was contractually obliged not to share the data, it can't. But most people did. Most people accept the default option, which is share as much as you like. So the contractual obligations are binding, it's just people don't understand it enough to do it. And that's where psychologists become relevant, so that we're making consent processes that are meaningful to individuals, as opposed to tech companies which are using nudges and sludges to steer people to the worst, most data sharing outcomes.
But if an employer gets hold of this chatbot, Simpatica, and says, okay, this is a good way for me to monitor or address the mental health of, my 700 staff. So I'm going to send it out to them and says, okay, can you please go and do this? And most people will come back and says, you're fine, and there'll be some people that are not. And then we will then try and address it with our in-house psychologists or whatever. So if that happened, should the company make it mandatory for their staff to fill it out, or optional?
Well, that's an OHS question, isn't it?
You can't make it mandatory.
No.
You can't. People have choice and control. You can explain why the data is of use for the individual and why it makes sense for the company and why you care about your people and why you want them to be a part of a community that looks after their mental health and their well-being. And this is a tool to help you get a pulse check on what's going on in that company. And you see big companies do that and they do it well. You see other companies do it and they use it as a stick.
Mm-hmm.
And that becomes career limiting. So you see that in military populations where the chances of people devolving what's going on for them are 0 to 0.
And particular cultural groups as well.
Yeah.
So, yeah, it could be the companies that probably need to assess the mental health of the staff are the ones that people won't want to fill out the thing for, because
It depends on how it's done, because it's all about design choices. Because what we're saying is we want responsible, trustworthy technology, and that happens here on back here on this bit, which is the pre-diagnostic therapeutic goods approvals process. There's different ways of designing technologies that
to make it trusted.
to display trustworthiness, actually, because that's really what we're talking about, that the person collecting the information and giving the feedback is trustworthy. And there's ways of showing that, and there's also ways of asking consumers questions or employees questions that are autonomy preserving rather than the other way around. And
how do they show that?
How do they show that? Well, it's partly about where one example is where default settings are set. So asking people to opt in. Would you like to use this tool? Yes, I would. Would you like to use this tool, just have a trial with this tool? Yes, I would. Do you want us to share the information? Can we share the information with your employer? No, I don't want you to. Do you want to know more about our privacy settings? Do you want to understand what we do with your data? Do you want to understand how it would be shared with your employer? Giving people options to explore those, and generally asking people to opt in is one way of illustrating trustworthiness. And then it's on the employer, because one of the criticisms of mental health initiatives, I think, at workplaces is that they're empty. Here's some fruit, here's a meditation session, here's a survey, but nothing changes, right? Yeah. Now, all of those might be good, but if employees think that they've shared information about themselves and nothing's changed, that's as much as a dampener on trustworthiness as taking the information and then going to the one person who happened to be the, non-neurotypical person on drugs to help them manage the workplace, who really didn't want anybody to know that, but then gets found out.
Anything else to say on if it's used in an employment situation?
The only other thing I'd add is performance. I mean, we use technologies to enhance performance all the time. You only need to look at our elite athletes, even in defence, performance enhancing. Increasingly, we're looking at how can we use machine learning to improve performance and increase productivity.
I would say that that's actually a good example of what we might not... There's a really good lesson to be learnt in how we use data with athletes in the military, because athletes have almost the most data collected about them of anybody. That their every movement is monitored, and there's a beautiful exhibition at the Science Gallery at Melbourne Uni on Adam Goode's data, actually. But athletes don't control or own that. They sign away their data when they sign up to be elite sports people, and yet that data is crucial to how they do their job, right? So that's an example where we could actually imagine a much more trustworthy system of data collection, where we understand that the athletes themselves, particularly sports people who often move clubs, have an interest in the outcomes of that data and would like to share the benefits of it rather than just the club.
So isn't this about intent? Ultimately, what are you planning to intend to do with it? Yes. So if you are an employer in a population that have high stress, like ambulance officers or whatever, you genuinely want to know how they're going. And so therefore you can try and do something about it, and so therefore we can start collecting information. There are things like voice surveys and all sorts of stuff that's around. Problem with them is that they have low numbers and it's really hard to actually make sense of it. But if the intent is actually truly to actually understand what your population is where they're up to, that's perfectly fine. If you're planning to do it to actually find out what they're doing, to actually try and manage them into a certain direction that potentially of a commercial interest or whatever, not so fun. So that's where it's going to become grey.
And if it's being run by a commercial organisation, there may be a demand to sell the data. There may be a bidder for buying the data.
So that can happen with registries, medical registries, where you're basically collecting information on, say, a new drug. So that happens in a range of medical conditions. So, and I'll use asthma for example, where there's a whole different types of treatments of biological agents. There's a severe asthma registry, and so people actually, the medical profession put the data onto it. The patients have to sign consent for that data to be there, and that registry can be sold to the pharma for what they've put in for their own particular drug, to actually understand what's happening in the real world. So that already happens. Again, it's about intent. And there's a whole process around registries. It's quite grey at times, but it always gets down, what are we planning to do with this?
Yeah. Sorry, I was just thinking, yes, there's a group at my university which has a number of registries that relate to psychological conditions already. Yes. And they're very, very careful about the consent forms and how they're sucking the data into the registry so that nobody's data is ever included without their explicit consent. And if you do it that way, then there's really no reason why people can't have the opportunity to participate in other studies later on or to have their data analysed. As long as they understand what's happening to them, that's absolutely fine. It's just making sure they understand. One of the things, and this time wearing my HREC hat, one of the things that really strikes me is how often the researchers themselves don't understand what it is they're asking of their participants. So they will say something in an ethics application like, nobody but the researchers will ever see this data, and yet they're gathering it on something like this. This is an Apple Watch, and it's going somewhere up into the cloud into some other companies. And in fact, the national statement actually caters for that. Section 3.1.66 actually says that if any third party is going to see your data, your participants must be informed about this and must explicitly consent to that, which is perfectly good. But how many people apart from me know about section 3.1.66? And the researchers, in all honesty, not because they're bad people or they're trying to do the wrong thing or they're trying to cheat the system, they don't stop to think, where could the data actually go? They don't, for example, think about the fact that many journals require the whole data set, raw and unprocessed, before they will even send an article out for review.
And I'll add, the on sale of data is another matter again. Yeah. Like, just because you've collected it for research purposes does not mean that it can later be sold. And in fact, that's not consistent with the reasonable expectations of consumers often. And in fact, the studies that have been done on consumers' views about contributing data to medical research is that they believe in medical research, but they're less happy with the commercialisation of the data. Yeah. Hence the need for...
Yeah. I mean, again, the national statement does try to cater for that. If you look at chapter 3.3, which is the one that relates to genetic and genomic data, they're very, and chapter 3.2, which relates to biospecimens, they're very, very careful to say that consent must make it clear to people who is going to get any commercial data. Section 3.2.12, which talks about consent for biospecimens. Sorry, I'm a kind of walking national statement. It's my superpower. But it actually says specifically in that section that, you know, you have to make it crystal clear, and also in 3.3.10, which is the same for genomic data. But people don't read it, they don't know it, they don't incorporate it in their consent form unless they've got an ethics chair like me who knows the national statement back to front and upside down. People don't pick them up on it and say, but you haven't included that and you haven't included that. And it's not done it really isn't done out of badness. It's just done because people don't know that the guidelines are already there.
Just changing gears a little bit. Terry.
Sorry.
No, it's fine. Terry, I just want to ask you, on the model you've got down in front of you, is it when do we move from the chatbot or the conversational AI to a human? Is that quite clear when that transition should occur?
No, not to me. It really, there are, I'm not trying to be evasive, there are deeper questions. I want to know what data is being collected. I want to know what instruments and methods are being used to form conclusions from the data supplied. I want to know whether it's categorical data or is it data that does admit of some gradation, a whole range of things that in the field of testing in psychology, and my medical and other colleagues will know this, has been investigated for a long time. I mean, typically at the moment you go into some sort of professional who will have an 18-question checklist. Now, in the hands of a treating professional who wants a quick diagnosis of whether this person is displaying symptoms of depression that actually need some clinical management or something like that, that's fine. But as 18 questions, checkbox questions, in an AI thing like this, there's so much data missing, you know what I mean, that the clinician has available to them or will get available to them if they feel they need it. So I can't answer the question without you telling me or showing me on a screen, here's what we want to ask, here's the way the person can answer it. Then I'd want to take Bruce's point, in the field of testing, I'd want that rigorously normed and validated. Before I would be prepared to take it anywhere beyond a feedback report. So there are sort of, with respect to those who put it together, Simon, that's probably partly you and you asked me here, there are some very, very fundamental questions that I reckon we're not talking about here. And it makes answering that question about when you move from artificial or a bot to a person or whether you need to move. I mean, it might not be important. It makes it really hard to answer with a simple yes or no or here.
What do you think, Jane?
I think we've relied for a long time on survey instruments as blunt tools, and there is no blunt tool, regardless of the psychometric properties of them. I think increasingly what we're looking at is functional impairment, which is separate to diagnostics. And I think if we're far more interested in functional impairment, then it's a different conversation about what can technology do versus what can a human do, and what are the conversations that you need to have, and where is their warm handover. And I'm with you. We don't know the answer to what can tech do, what should a person do, what is technology better at doing than a person, how can we integrate the tech and the person. But what I do know is at the moment we have no warm handover. We have technology sitting here, we have online services sitting over here, we have psychologists sitting in offices, other mental health professionals doing what other mental health professionals. There is no joining of the dots of whether that's technology or whether that's professional. And that to me is a system that's completely and totally and utterly broken. And we need to think about, and we're not going to answer it on this panel, but we need to think about how do we actually create systems that are actually systems and not just pieces of puzzle that create different disciplines that are trying to achieve something that they just can't do because humans are complex nature.
I wish I said what Jane said.
So one of the things you can do is start biting off a chunk and have a go at an area. And when I was just listening to Jane and also Terry, there was one area that we actually have linked a bit, is actually employee assessment. And so I've just started at the University of Melbourne, been there for a few months now. And part of my 8 interviews was 2 hours of neuropsych testing.
Right.
And which was kind of interesting because I did say it was only going to take 50 minutes. It sure didn't. And it was fully online.
You're obviously complex.
Yeah, special. Some people would argue. I might get my kids in the room at this point. They have definitely an idea. So, but it was kind of interesting going through it. Clearly there was an AI behind it because it was really trying to direct me in the way that the questioning was happening. Produced a report, and then I sat down with a psychologist a couple of weeks later to go through it with another hour as well. So clearly that was something that had been developed by them, tested, validated, and so the clinician at the other end of it also knew what they were coming up with as well. I read it, thought it was okay. My wife's a psychologist, so when I just said, is it going to find if I've got a brain tumour or not, to go to an idiot? So it doesn't do that. It has a very clear direction. Is it a pass or fail? Typical psychologist comment. There's no pass or fail. And so, but I got the job, so I think I must have passed. But it was actually a nice example where, that actually saves time and also potentially has an outcome. Another one where I was potentially going to work on, which is a bit more controversial, is end-of-life decision-making. So for some people, find it extremely hard to speak to their family about it or to speak to a clinician about it. And the construct of being able to go through an end-of-life decision-making process with potentially augmented reality, avatars and what have you, that you own, that you can potentially modify, I didn't mean that, is so you need to be careful about it, but there is definitely a need in a case like that where it's actually done quite poorly, especially in Australia for multiple reasons. But now we're actually having the euthanasia laws and people can actually end their life in certain circumstances. It's becoming really quite important. So again, it's something that's really narrow, that has a beginning and an end that you might be able to test it on.
So what you're telling me also, when you were saying discreetly, was about the intent, wasn't it? Because for a job interview, the intent is very, very clear for that AI.
Yes. And it's interesting, I've interviewed for another senior position in the faculty and got a couple of people and actually seen the reports. Again, we signed up in terms of confidentiality, and you look at it and you go, wow, it is, we've got to make some decisions here because people are different. And how did that resonate with us in terms of the interview process? And it's part of the mix of making a decision as well. So it becomes tricky. However, it's already an example that's been used.
Okay. So I just want to get on to the use of data for research. Because we talked about collecting data, etc., but some of the data that we could collect here would be very useful for research. What's I'm trying to paint an ethical dilemma here. Is if you were going through the data and you saw something in the data that was deeply alarming, like someone was suicidal, or you recognise something in there, and you've been given this data to do your research, do you have any responsibility to ring an alarm bell, to raise a red flag or do anything? Or do you just treat the data as data for research?
Well, the simple answer is that you have to ask your participants ahead of time what they want you to do in that sort of case. In the case of genomic data, because it's a special case, you explicitly have to say to people, do you want to know the findings? So say you're testing for something horrendous like Huntington's disease. You have to actually say to people, because it's not going to affect just them, but all their blood relatives, and potentially their married relatives, because they'll have children who are blood relatives, so it affects the whole family. So you actually have to say, do you want to know the results or don't you? If you're doing something like scanning and you think there's a possibility you might turn up an exceptional result like a brain tumor, where you're actually scanning, say you're actually using something like an MRI scanner to actually see what people are thinking while they're doing psychological tests, but that scanner may also pick up the fact that they've got a brain tumor, which you weren't expecting and you weren't looking for. You would agree beforehand that if an unexpected finding turned up, that you would tell their GP, because it's not fair to expect the researcher, who is a psychologist, to say to somebody, by the way, you've got a fatal brain tumor, surprise, because that isn't really what they're trained to do. They're trained to do other things. So you basically get these people to give you their GP's details and say, if we find something unexpected, we will send that information to your GP, who will contact you and talk to you about it sensibly. So you basically just make arrangements ahead of time with what might or might not happen.
It happens all the time,
Yeah.
that issue.
So it's not unusual.
Not at all.
But
When you
Go on,
say the
Jerry.
data should be useful, other than being useful to the person who reports the data, why would we even be collecting identified data? If it's de-identified data, and that's what you mean by useful data, so in other words, we'd like to see what in a population of 10,000 people, how many people report levels of anxiety significant. There's no problem, as I understand it. Jump on me if I'm wrong. So I think you've got to differentiate between data that's uniquely identified and what its beneficial purpose is, from data in the big data sense of the word, and what it might tell you about population health or the general cultural health of an organisation or something like that. So I keep doing this here. I just think we're going to keep pushing back to some fundamental distinctions that'll be need to be made to solve this. Well, it's a dilemma, isn't it? I think the basic idea, I'd like to see something like this go ahead, but there's some real issues in there.
Well, yes, but you've got to remember that secondary data, since the revisions to the national statement that came into force on the 1st of January 2019, secondary data, now you need explicit consent one way or the other. You have to either get consent from the participants in advance, or you have to be able to apply for a waiver of the requirement for consent, where you're asking the ethics committee to consent on behalf of the participants because for some reason you can no longer contact them. It may be that the numbers are too large, or you no longer have their contact details, or whatever. But if you think, and I spend an awful lot of time saying this to my researchers, for pity's sake, apply for future data use when you're putting in your original ethics application, because it makes life so much easier for everybody later on. And sections 2.2.14 to 2.2.18 of the national statement cover that in all its gory details. And there's two ways. You can either ask for specified future data consent so that you yourself can reuse the data, or you can ask for unspecified, where you can share the data with anybody you want to. And as long as your participants know that's going to happen and they agree to it, then you can go for your life.
But that's for research purposes. If you're talking
Yes,
about
that's what we started out talking about.
But yes, we were talking about research purposes, but I'm just making the point, if we're doing it, if we have some sort of chatbot tool that's being used by a commercial firm, then actually the Privacy Act requirements are similar. But it sits within the Privacy Act about what you're asking for, and in fact the rules around sort of commercial secondary use are tighter than they are probably for research uses. And again, if you're dealing with someone who's using the tool or the chatbot because they're concerned about their mental health or their well-being, then we run back into those problems raised earlier about how do we ever get that person to consent to abstract future uses. I mean, I actually think that issue arises sometimes in research. Not everybody has such a robust chair as you, I think.
But no, you're quite right. I mean, Section 95A would allow you to show that there was a community advantage that was so great that you had the right to use their data without their consent. But there's some quite strict requirements attached to Section 95 and Section 95A. And the states have their own equivalents.
Just to add, from a research perspective, when we did Young and Well CRC, which was 39 trials, for want of a better word, randomised controlled trials, interventions, all tech, we went through ethics committees for every single one of those trials. We had a standard statement which young people agreed to, which was, if it looks like you are at harm and at risk to yourself, or you're at risk of harming someone else, we have a mandatory reporting requirement, which is we will let you and or whoever you have agreed to consent to know. I mean, that was just stock standard. I mean, that's true of all randomised controlled trials. That's just a stock standard. When it comes to the commercial, though, and this is, Jenny, where I'm interested, because you can collect any data without having to mandatory report on self-harming behaviour.
Well, you can, that's right. Though I think you have professional obligations. But yes, there's nothing in the Privacy Act about the responsibilities in relation to data that may reveal harmful outcomes. That's entirely right.
Which I always then come back to the importance of the science, the research and the implementation, and why you need to put these things through rigorous processes to determine does it cause harm or not.
Though you can disclose if it's necessary.
Yep.
So you say that one can collect any data without having to report self-harming behaviour. Is that what you're suggesting?
So we're just saying that the rules between the research data collection rules and Privacy Act rules that apply to commercial enterprises are different. So there's no, if you're collecting data under the Privacy Act, there'd be professional responsibilities in relation to findings. The Privacy Act is concerned about getting consent for uses of data, not there's no mandatory obligation about reporting adverse outcomes you might find there. There is an exception that you might be able to disclose the data in certain circumstances, but those obligations don't sit there.
But if you're a registered health practitioner,
that's
another question.
Yeah.
And it's not even commercial. As an NGO, you don't have to report.
No, it's just outside of research.
It's outside of research.
Yeah.
So it's not even a commercial issue. It's a data.
Right.
It's a data rights, data privacy issue.
I've got one last question. It's a big one for the people who are running the chatbot, and so it's important for Simpatico and important for Together AI. It's about duty of care. So, what is the duty of care the people who are running the chatbot have towards the people who are using it? I mean, at the moment, if someone looks like they're suicidal or something, they just are given numbers to ring, which is, contact this, do this, this can get you help. What more can you suggest that in a chatbot type situation, what is the duty of care that is ethically, maybe not legally or not because they're not practitioners, but that is associated with practitioners? What duty of care that would you like to see being adopted by the companies that are running these chatbots?
Well, there's an OH&S Act that talks about people being as reasonably as much as practicable, providing a safe workplace. And if someone's describing something that's unsafe to them or other, my duty of care, whether I'm a health practitioner or not, is to respond to that in an appropriate way to make sure that person is safe.
If it takes place within a workplace?
Certainly, yes. I mean, I would as a human being otherwise, and so, yeah.
I thought there was a case in Western Australia where it was decided that there's a general duty of care if there was a road accident in Western Australia, wasn't there, where a court decided that the person who walked away from it and didn't do anything did the wrong thing?
I don't know about that case. Generally the law's a bit odd here. There's no duty. Generally, there's no duty of care to act. There's only a duty of care not to cause harm. But if you're producing a product, then that changes already, because you're not the bystander who happens to see a child. The example we use in law is you see a child drowning. Do you have a duty to rescue? No. But if you provide the flotation device that means the child's drowning, then your duty is quite different.
So, I mean, normal consumer law would apply with this product.
Yeah, that's right. So
Except
it's a
that
product.
people
No,
aren't
it's a
paying
product.
for it.
No, it doesn't matter if you.
In trade or commerce.
In trade or commerce, yeah. It won't, in the employment situation, it might be a bit different because it's part of the employment situation.
And isn't there a Good Samaritan Act? If someone's arresting in front of me and I try to do CPR and don't
And I
quite get
fail.
it right,
Yes, if you
then
act
I'm
as the good
protected for that.
correct. But if I provide a product and I don't have to ask for payment in return, I just have to be providing a product in trade or commerce, which can be my business is providing the product, then I owe a duty to use reasonable care and skill in the provision of the product. But generally that goes to the process, so that I've designed the product carefully, I've thought about the things that could go wrong, I've responded to them, I've taken appropriate precautions to ensure that the product won't cause adverse harm. But if harm eventuates, but I've still taken all those steps, then I, the provider of the product, won't have breached that duty of care.
So what are the appropriate precautions in this case?
Well, I come back to warm handover. I think there's got to be a different model of care.
Yep.
At the moment, it's a ring 000, ring lifeline.
Yes.
It's not adequate.
and if it's actually de-identified data, this is where it's going to be very difficult for an organisation. So, because you'd like to identify them somehow, so you can actually use your duty of care to do something. To me, I think it's critical. I think this goes to the heart of the culture of any organisation, that if you find that you have due to the organisation itself that people are doing self-harm, and you're choosing to say, not my problem, mate, seriously, then it's commercial suicide for starters, let alone culturally suicide. So they have a huge duty of care before embarking on this. The extra step is that there needs to be a human interaction handover, and there needs to be some mechanism for the people who are identified to be at risk, whatever that means, have an avenue to be able to follow.
So as soon as that handover occurs, then it's being handed over to a registered psychologist, and therefore
To an appropriate person or whatever it could be, yeah.
All right. Well, if it's a registered psychologist...
Well,
then
it might not be, because the mental health space is dominated by risk aversity, and that risk aversity is directed at suicide. So we ought to say that, and that's why it comes up all the time. But there are other circumstances where the risk identified is not to the reporting person, where they report that they're involved in a domestic violence situation and are going to kill their partner. There are actual circumstances where anyone in the community is to obliged to report risk, and that's in the categories of offences that get caught in that terrorism type thing. So again, it's one of those disaggregation questions, I think, that I actually like things that Jane was saying earlier about getting the warm transfer, and I think you can manage that with a bit of foresight and work and resources and things like that. But it's where the harm identified is not to the person reporting. And there I think there's some real thorny questions. And in fact, in my psychological practice, they're the ones that have troubled me most. It's where I've thought that a person might be perpetrating sexual abuse on a child. It's where I thought somebody was considering what in the old days we would have called mayhem. There's some action out there in the community that was not just dangerous to them, but actually put others at risk. And so I think the whole discussion again needs a bit of disaggregation. I think the management of suicidal risk is one issue. These other things that are real too need some attention.
Has anyone got anything more to say on that?
Well, just that I completely agree with the warm handover idea, because, if we just, I'm going to bring it back to suicide just for the obvious example. Overreaction to suicidal ideation can also have some very detrimental effects. If somebody says, yeah, I was just having some thoughts that maybe life isn't worth it, and you're suddenly having the ambulance screaming down the road, they're never going to tell another person again. No. Never. And so I think, our best prediction tools that we have, for research into suicidology, they're terrible still. And I don't mean that as, we've done something wrong. It's a low base rate phenomenon. There's a lot of factors that go in. Who moves from passive ideation to active ideation? Who moves from ideation to, intent to, making actions to completing? And, we've got some okay-ish algorithms for trying to identify what are the risk factors, to put the person into risk categories. But again, their ability to predict who is actually going to make an attempt at their life or not is very, very poor. You need massive samples to even start to get statistical significance, there. So, I would be very concerned if we had an AI system that had, the direct line to 000. I'm in Australia now.
But that's where AI can be actually really good, because they can actually find that needle in the haystack.
That's true.
What you do with the information, I think, is where the care needs to be taken.
Yeah.
And Terry, you alluded to it before, and I'm involved in an organisation as a not-for-profit on the board that deals with this in child sexual assault. If all of a sudden this finds out that someone had child ideations and they're in a youth worker organisation, we have a problem. And if it's a commercial one, you might be saying, well, it's not my problem. But it's a disaster, and the statistics of it are extremely high. So, this is where that crossover is critical.
So, if I was going to put on my AI ethics hat, as opposed to my sensible lawyer hat, the question I would ask, having heard this conversation, is why do we want a chatbot? We're so worried about the warm hand handover. Why do we want an artificial agent in the mix at all? Why don't we just have humans there?
It's efficient.
But is it efficient?